Today our topic is newborn screening. Newborn screening is a program that aims to find out if an infant has a genetic or the metabolic disorder that may lead to the mental retardation or even death if not treated early, can affect both male and the female children. Early diagnosis and the initiation of a treatment along with the appropriate long-term care are essential to ensure the normal growth and the development of an affected child. Disorders tested in expanded newborn screening: endocrine disorders like primary congenital hypothyroidism, congenital adrenal hyperplasia, amino acid disorders like phenylketonuria, maple syrup disease, hemoglobinopathies, thalassemia alpha major, beta thalassemia major, HBE beta thalassemia, HBH disease, constant spring disease, HB variant, homozygous AA, sickle cell anemia, sickle cell disease, HBsOC disease. Organic acid disorders like methylmalonic acidemia MMA, beta ketolase deficiency, isobutyryl CoA dehydrogenase deficiency. Fatty acid disorders: short chain acyl CoA dehydrogenase deficiency, medium chain acyl CoA dehydrogenase deficiency, very long chain acyl CoA dehydrogenase deficiency, and other fatty acid oxidation disorders. Newborn Screening Act of 2004. This program was integrated as a part of country's public health delivery system. It has now become mandatory. The Development of Health Act as a lead agency in the implementation of the law and included the NBS in its program Children's Health 2025. The goal of all the Filipino newborns will be screened for the common and the life-threatening congenital metabolic disorders by the year 2025. Study shows they have the enhanced case detection of the selected inherited disorder through the ENBS in the Philippines. California Newborn Screening Program screens for 70 disorders on its database. From 2005 to 2011, a total of 3460893 newborns were screened in the CNSP, which included the expanded newborn screening 11127 Filipinos in 199 confirmed having one of the included screened disorders. Why are these disorders included in the NBS panel of the disorder? Local prevalence, reversible if treated on time, and treatment is available. Why is it important to have the newborn screening? Babies have these metabolic disorders look normal at birth. One will never know that the baby has a disorder until the onset of signs and symptoms, which may already be irreversible, such as the mental retardation and death. What will happen if the child has any of this disorder if not screened and treated? In congenital hypothyroidism, there will be the severe growth and the mental retardation. Effect if screened and treated will be normal. Congenital adrenal hyperplasia, there will be death. Galactosemia, death or cataract. Phenylketonuria, severe mental retardation, and J6PD deficiency, severe anemia, and the keratitis. Organic acid disorders, people will have the development delay, breathing problems, neurologic damage, seizure, coma, and early death. Fatty acid oxidation disorder, development of the physical disease, neurologic impairment, sudden death, seizure, coma, enlargement of the heart and liver, and the muscle weakness. In the hemoglobinopathies, painful crisis, anemia, stroke, wealthy organ failure, and death. Urea cycle defect, seizure, mental retardation, and death. Amino acid disorder, mental retardation, coma, and death from the metabolic crisis. When is newborn screening is done? Newborn screening is daily done after the 24 hours from the birth. All preterm, low birth weight, and the sick infants must be collected from 24 hours from birth. Gestation, low birth weight, infants have less than 2000 grams at birth. If the sick infant, those admitted to the NICU, requires intensive care. For the preterm babies, a repeat collection must be done at 28 days of life. For low birth weight, which is lesser than 2000 grams, a repeat collection must be done once the patient already weighs 2000 grams or more. Falsely elevated TSH, false positive screen CH, falsely elevated 17 OHP, false plus screen CAH, falsely low galactose and the amino acid due to the inadequate feeding, false negative screen for GAL and fatty acid disorder. Golden period for CH is 14 days, CAH 7 days, phenylketonuria 14 days, galactosemia 7 days, MSUD 6 days. J6PD deficiency, they have carnivorous hemolytic anemia. Golden period. This is a period of time during which there is a greatest likelihood to prompt a medical treatment will prevent the complication. Motivation of parents, collection of a blood sample, sending of samples to lab, laboratory tests resulting and the releasing of results, recalling of patients and the management of cases will also be done. This is the main process what we should do to the patient and the doctor relationship here. In motivating the patient, we should educate the parents during the prenatal visit. And collecting the samples done in the participating health facilities like hospital, health center, rural health unit, lying inside or birthing facilities by any of the following like physician, consultant, resident, municipal health officer, nurse, medical technologist and the midwife. Collecting samples in right time, right place and right procedure method. Right time, this is the baby is screened after 24 hours of life, preferably on the 25th hour of life. Baby had the adequate milk intake before any procedure such as BT, TPN or before the putting baby on the NPO. Filling out the information needed in the filter card. Use black or the blue ball bit. Do not use a pencil. Fill out all items legibly or completely. All of the information on the filter card is important for the interpretation of a result and the critical for the immediate recall of a patient with the abnormal values. Prepare the necessary materials. Clean gloves, warm moist towel, 70% of the isopropyl alcohol or the sterile water, dry in the wet cotton balls, swabs, NBS filter card, properly filled out sterile lancets, microspray, tape and the buying rack. Warm the baby's heel for the sufficient or the free flow of blood. Hold the baby's leg lower than the head. Warm baby's heel with a warm moist towel for the 3 minutes. Temperature must not exceed 40 degrees Celsius or gentle rubbing of the baby's heel. Clean the puncture site. Clean the area thoroughly with the 70% of the isopropyl alcohol or sterile water swab. Dry the puncture site. Wipe the prospective puncture site with the dry cotton ball to prevent the contamination of the specimen with alcohol or the sterile water. Heel prick method. Make 2 punctures in the quick session on the lower lateral borders of the heel. Do not puncture site. Arch of the foot, swollen area, previously punctured area and fingers. Blood is stopped to the special filter card. Apply intermittent pressure to the surrounding area of the puncture site. Do not squeeze the heel too hard as it may causes the interstitial fluid to leak and the contaminate specimen. If the blood flow slows down, release the grip and wipe the puncture site again with a dry cotton to remove the clot. Handling and sending the samples to the NSC. Proper handling is necessary to prevent the contamination and maintain the integrity. Intermediate transport of the samples pressure, promptly testing and analysis resulting in the timed diagnosis of the baby's condition. There is designated pickup time. Disorders screened in the NPS. Congenital hypothyroidism. Children can be born with the inadequate thyroid functionalities due to one of the severe disorders like thyroid dysgenesis, small thyroid, hyperplastic ectopic aplasia. Severe physical and mental delays may occur if not treated immediately. Cortisol deficiency, they have the low blood sugar. Aldosterone deficiency, low serum sodium, high serum potassium. Androgen, if it is excess, male features become visible. Affected female presents with the ambiguous genitalia. Phenylketonuria, there are conditions in which a baby is born without the ability to properly break down an amino acid called the phenylalanine, characterized by the high level of the phenylalanine in the blood or the phenylketone in the urine. Pattern of inheritance, autosomal recessive one. Manifestation like edema, aciditis, hepatomegaly, cataract, mental retardation, cirrhosis of liver and the growth failure. There will be brain damage, cataract, jaundice, enlarged liver, kidney damage if a galactosemia infant is given milk, unmetabolized milk, sugars built up and damage the liver, eye, kidney and brain. Galactose 1-phosphate uridyl transferase enzyme, this is the most common one, galactose epimerase. Management, low protein diet, phenylalanine free milk diet, no meat, dairy products, dry beans, nuts and eggs, cereals, fruits and vegetables in the moderation. Clinical manifestations like vomiting, hyperactivity, seizure, musty or the mousy urine odor, seborrheic or eczematic rash, mental retardation. Phenylketonuria. There are conditions in which a baby born without the ability to properly break down an amino acid called the phenylalanine, as I said before. Treatment and management: cortisol and the aldosterone replacement, submitting OHP, increased submitting OHP is a confirmatory test. Abnormal genitalia, pediatric surgery if the child is past 3 years of age. Regular follow-up should be done. Classic non-salt wasting. Here the deficiency of the mineralocorticoid is not that severe. These children do not have the salt wasting but can develop the other features as above. Usually no signs of symptoms in the newborn period, present in the later life. Childhood or the adulthood due to the signs of the androgen excess, hirsutism, excessive acne and the initial accelerated bone growth but reduced final height due to the premature fusion of the epiphyses. Females have the infertility, cleidocromegally and the menstrual irregularities. Classic salt wasting CAH, most common type, occurs due to the severe deficiency of both cortisol and the aldosterone and the excess androgen. Newborn period, failure to thrive, dehydration, hypoglycemia, hyponatremia, hyperkalemia and damages genitalia in females. Childhood, if these children do not receive the adequate hormone replacement, they show the signs of androgen excess, precocious accelerated in the pubic hair development, initial accelerated growth but reduced final height. Cortisol, there will be the maintenance of the normal blood sugar. Aldosterone, there will be the maintenance of the normal serum sodium. Androgen, testosterone, male sexual differentiation. Congenital adrenal hyperplasia, a disorder in the hormone production of the adrenal gland that causes a severe salt loss, dehydration and abnormally high levels of the male sex hormone in both boys and girls. Treatment and management: thyroid hormone replacement, levothyroxine at 10 to 15 mcg per kilogram per day. Have to confirm the thyroid function test: low T4, high TSH. Naked thyroid ultrasound, there will be the thyroid scan. Dilate manifestation: people can give the mental retardation, growth retardation, delayed skeletal maturation, delayed dental development and the tooth eruption, delayed puberty. Clinical manifestation of CH in the infants: hypotonia, prolonged jaundice, inactive defixation, umbilical hernia, pallor, coldness, hypothermia, edema, rough, enlarged tongue, dry skin, open posterior fontanalis, delayed overall development. Outcome: if the treatment is instituted within the first 2 weeks of life, mental retardation, cirrhosis and growth failure may be prevented. Can't present at birth may not regress, but they are not likely to progress. Avoid milk and milk products for treatment. Newborns, lactose-free or the galactose-free formula, soy-based milk formula will be given. 12 to 24 hours after birth, maple syrup odor in the semen increase in the BCAA level. 2 to 3 days ketonuria, irritability and poor feeding. 4 to 5 days lethargy. 7 to 10 days coma and the respiratory failure will be given. Glucose 6-phosphate dehydrogenase deficiency, a condition in which the red blood cell breakdown when the body is exposed to the certain drugs or the stress of infection. Methylmalonic acidemia, caused by the deficiency of the enzyme methylmalonyl coenzyme A mutase, which catalyzes the conversion of the methylmalonyl CoA to succinyl-CoA. Clinical manifestation like poor feeding and lethargy, neurologic deterioration, metabolic acidosis, hyperammonemia, anemia and death. Pathophysiology: increased energy demand, decreased caloric intake, like fasting illness, increased muscular exertion, mobilization of the lipid stores, generation of the fatty acid. Defects in the transporters, translocated, so the enzymes involved in the process of importing the fatty acid into the mitochondria, failure to generate the energy, acute life-threatening illness. MCADD, high index of suspension, plasma acylcarnitine measurement, urine organic acid analysis, mutational analysis like K329E. Sickle cell anemia is one of the group of disorders known as the sickle cell disease. Sickle cell anemia is an inherited red blood disorder in which there are not enough healthy red blood cells to carry the oxygen throughout your body. Hemoglobinuropathy. This is a medical term for the group of disorder and the disease affecting the red blood cell. Screening for the SID and the thalassemia is important to help the patient get connected to healthcare services for the treatment and improving the long-term health. Medium chain acyl-CoA dehydrogenase deficiency, most common fatty acid oxidation disorder, autosomal recessive pattern of the inheritance, one of the least severe among FAOD. Heart and the skeletal muscles are not involved. First crises usually occur between 3 and 4 months and as late as 2 years of age. Most common manifestation is hypoglycemia. Others, the development of the behavioral diabetes, chronic muscle weakness, failure to thrive, and the cerebral palsy. Diagnosis NBS, urinary organic and the acid analysis, absence of the ketones in the patients under stress, plasma acyl carnitine profiles, biochemical clues like hypoglycemia, hyperammonemia, increased free fatty acid in the plasma, and the high creatine kinase. Clinical manifestations like muscular, sudden muscle pain and the weakness with the hypoglobinuria after the strenuous excess of fasting. Renal failure may occur, and the classic example is the carnitine palmitoyl transferase 2. Clinical manifestation is a hepatic, hypoketotic hypoglycemia, elevated liver enzymes, ammonia and uric acid, metabolic acidosis. Classic example is MCADD. In cardiac, there will be the cardiac myopathy, progressive heart failure between 1 to 7 years of age. Classic example is the carnitine transporter defect. Fatty acid oxidation effect during the prolonged starvation. Fat provides the 80 to 90% of the body's metabolic fuel through the fatty acid oxidation. Cardiac, skeletal, and the muscles dependent on the fat breakdown to meet their energy needs. Fatty acid oxidation occurs in the mitochondria and has the 4 components: the carnitine cycle, beta oxidation cycle, electron transfer, and the ketogenesis. Propionic acidemia results from the deficiency of the enzyme phencyl-CoA carboxylase stated in the breakdown pathway of the isoleucine and the valine. Vomiting, port feeding, dyspnea, seizures of the itself of the present within the few days of life. Metabolic acidosis, high anion gap, hyperammonemia, anemia, and the thrombocytopenia. Global development delay, hypertonia, and the gastric symptoms. Sickle cell anemia, swelling of hands and feet. The swelling is caused by the sickle-shaped red blood cell blocking the blood flow to the hands and feet. Frequent infections like the sickle cells can damage the spleen, leaving you more vulnerable to infection. Infants and the children with the sickle cell anemia should receive the vaccination and antibiotic to prevent the potential life-threatening infections such as pneumonia. Beta thalassemia, a heterozygous mutation, beta plus thalassemia, results in the beta thalassemia minor, in which the beta chains are underproduced. It is mild and usually asymptomatic. Beta thalassemia major is caused by the homozygous mutation in the beta 0 thalassemia of the beta globin gene, resulting in the total absence of the beta chains. Its manifestation clinically as a jaundice, growth as retardation, hepatosplenomegaly, endocrine abnormalities, and the severe anemia requiring the lifelong blood transfusion. The condition is between the two types is called the beta thalassemia intermediate with a mild to moderate clinical symptoms. A simple drop of blood saves a life. This is the major content. The major beta thalassemia results from the point mutation in the beta globin gene. It is divided into 3 categories based on the zygosity of the beta gene mutation. Alpha thalassemia, a drop of a globulin serves as the oxygen carrying component of the red blood cell, consists of two proteins alpha and beta. If the body does not manufacture enough of one or the other of these two proteins, the red blood cells do not form correctly and cannot carry the sufficient energy. Thalassemia is a heterogeneous group of blood disorder affecting the hemoglobin genes and resulting in the ineffective erythropoiesis. The decreased production of hemoglobin results in the anemia in the early age, and frequent blood transfusion are required to keep up the hemoglobin level. Sickle cell anemia, delayed growth at the puberty. Red blood cells provide the body with the oxygen and the nutrient needed for the growth. A shortage of the healthy and the red blood cells can slow the growth in infants and children and delay the puberty in the teenagers. Vision problems. Teeny blood vessels that supply the eyes can become plugged with the sickle cell. This can damage the retina, the portion of the eye that processes the visual images, and lead to the vision problems. Signs and symptoms usually appear around the 5 months of age. They vary from person to person and change over time. Anemia, sickle cell breaks apart easily and die, leaving 2 red blood cells. The sickle cell usually die in 10 to 20 days, leaving the shortage of a red blood cell anemia effect. The body can't get enough oxygen, causing the fatigue. Isovaleric aciduria results from the deficiency of enzyme isovaleric CoA dehydrogenase that catalyzes the breakdown pathway of a leucine. Accumulation of the toxic metabolite occurs, resulting in the neurological deterioration and the problems in the energy metabolism. Speedy feet order, clinical manifestation, developmental delay, hypertonia, recurrent vomiting, and the dehydration. Clinical feature for the organic acidemia, sudden onset of the encephalopathy, and the episodic metabolic acidosis, dietary restriction of the relevant amino acid, avoidance of the protein catabolism, carnitine, and the glycine supplementation. Additional metabolic disorder including in the expanded NBS, organic acid disorder, fatty acid oxidation disorder. Genetics of the G6PD deficiency, X-linked recessive inheritance from the mother primarily affects the male offspring. Antimalarial drugs to avoid: primaquine, chloroquine, ramaquine, pentaquine. Mothballs. The following substances should be also avoided in G6PD deficiency: astanal, doxorubicin, isobutyrenol, naphthalene, phenylhydrazine, pyridium, vitamin K analogs, methylene blue. Antibiotics like sulfonamide, sulfonylamide, sulfamethoxypyridoxine, sulfacetamide, sulfadimidine, sulfapyridine, sulfametazine, sulfamethoxone. Nitrofurantoin, nalidixic acid, ciprofloxacin, neridazoles, norfloxacin, chloramphenicol, fenzophylidine. How to confirm? We can do the CBC count to determine the level of anemia, increase the serum bilirubin, measurement of the actual enzyme activity of a G6PD. Management. They relies heavily on the dietary management, restrictions of the protein intake. Maple serum urine disease. The condition gets its name from the distinctive sweet odor of the affected infant's urine. The byproduct of the isoleucine has a characteristic sweet smell which gives the disorder its name. This is the disorder in which the body is unable to process a certain protein building blocks, branched chain amino acid, leucine, isoleucine, and valine properly. Treatment and the management is to avoid milk and milk product, newborn lactose free or the galactose free formula, soy based milk formula should be given. Thank you.